All right, hi everyone. Welcome to the 12th virtual shadowing session. We will be discussing the journey of trauma surgeon from classroom to OR. Just a quick reminder, if you have any questions, put it in the chat. We will have 2 Q&A sessions, one in the middle and one at the end of the presentation. So some upcoming topics: on August 25th, we have the finance and business and medicine. On September 1st, we have medical school vice provost. Sorry, I can't read that one. But
that'll be Dr. Beeson, who is the vice provost of the University of North Texas Health Science Center in Fort Worth, Texas.
It's exciting. And then September 8th, we will have a meeting with the healthcare advisor. And then September 15th, we have humanity and medicine. All right, I would like to introduce the virtual shadowing working group. We have myself, Elena, and then we have Reagan, Cheyenne, Taylor, Rachel, Ani, Miriam, Dr. Marchetti, and Dr. Ray Fowler. Dr. Fowler, take it away.
Thank you so much, Elena. As an old man in medicine who's been doing this for going on a half century, I am now here in the busiest trauma center in the United States, which means one of the busiest hospitals in the world. We have attracted over the years some of the most just incredible talent of physicians, nurses, staff members who render care at all hours to all ages, all genders, all ethnicities, no matter what the condition. We have the Parkland Trauma Unit and the Parkland Burn Unit. And during my time here as faculty, it has been my just esteemed pleasure to work with someone who I think is one of the finest individuals in the world. Dr. Brian Williams is joining us. He was at Parkland for many years as trauma surgeon and someone who I came to depend on to help me during the times of chaos that we often have in that emergency department. Whenever I would see his sweet, smiling face coming through that door, leading a covey of residents and students behind him, all of whom for whom his word was law. Of course, his word quit being law in the emergency room. Sorry, Brian. And I had the opportunity for many years, as did Brandon Morchetti, who's with us tonight, who spoke a few weeks ago, to be able to work alongside Brian Williams. He is a wonderful doctor. He is a deeply committed humanitarian who cares about the human condition. It was such a pleasure to work side by side with him. Not too very long ago, Brian left us in Dallas, Texas to move up to the winter hinterlands of Chicago, where he now serves as Associate Professor of Trauma and Acute Care Surgery at the University of Chicago. It is just an unspeakable pleasure for me to be able to welcome my dear friend and someone I respect so very much, Brian Williams. Brian, take it away.
Thank you very much for that introduction, Dr. Fowler. It's good to see you again, albeit virtually. And for all of you that are joining tonight, thank you for taking the time out of your evening or day, wherever you may be in the world, to listen in on this. If you're interested in medicine, I will say it is a profession that has rewards like no other. And I can't imagine doing something else with my life right now. Now, I'll talk about what it is to be a trauma surgeon, but I should say that Dr. Fowler mentioned that earlier. Before this, I was in the military. I was in the Air Force. I went to the Air Force Academy for undergrad, and my major actually was aeronautical engineering. So I served time in the Air Force as an engineer for 6 years with zero plans to become a doctor. It wasn't even part of my life plan. It was not on my radar. Several events kind of pushed me in the direction. And so when I transitioned, it was pretty much stopping the career progression that I was on to pursue something else later in my life. So I'm what they would call a non-traditional medical student. I went to school when I was 28 to go to medical school. I had a prior career, and I had a engineering degree, not the, I guess, more typical sciences and chemistry, biological sciences, pre-med type degrees. But I feel that that certainly prepared me for what I was getting into. When I went to medical school, I had no thought about what kind of doctor I'd become. I wanted just to become a doctor because to me, doctors are that one group of people that serve humanity every day. And I thought, like, how great would that be to go to work every day knowing that you were doing good for humanity, for society, and for strangers. And it wasn't until my third year medical school, which is when we started our clinical rotations, where I did my rotation at Tampa General Hospital in Florida. I went to USF, University of South Florida, for medical school. And during a trauma rotation on the second day, I was like, this is it. This is what I want to do. I enjoyed the fast pace. Patients come through the door, they're trying to die. And the team would just go to work and bring them back from death and go to the OR and go to the ICU. And I thought, this is amazing. That's what I want to do. And these are my people. So I didn't choose trauma surgeon. It sort of chose me and grabbed me and never let go. But I think when most people think about trauma surgery, they probably think of gun violence because that is what dominates the media when we talk about trauma surgeons. When you see trauma surgeons on TV talking about their job, is usually in response to some sort of mass shooting or the scourge of gun violence. And that's certainly the case here in Chicago, which currently is having record-breaking gun violence this summer during COVID. If you talk to people like Dr. Fowler or Dr. Marchetti, they may describe trauma surgeons like this. We have a reputation for being gruff and intransigent and want to do things our way. And if you don't like it, just get out of our way. I would like to think that we are not like that. There's a new generation and we are much more collaborative and professional. But certainly there's a reputation for trauma surgeons of being this sort of, it's my way or the highway type of personality. But here's the thing with trauma surgeons, and it kind of goes hand in hand with what emergency medicine doctors do. We spend our time in the ER taking care of people that come through the door that are acutely sick. And for a trauma surgeon, we're dealing with car accidents and falls and also the gunshots and the stabbings. But the vast majority of who we care for are innocent people that get hurt every day through no intentional fault of their own. It is true we deal with a lot of intentional injuries, but there's a lot of unintentional injuries that we take care of as well. And the trauma surgeon's job is to, one, if there needs to be an operation to prevent loss of life, such as someone's shot in the abdomen, or they were in a bad car accident and they're bleeding internally, or they fell from a ladder and they hit their head, the trauma surgeon needs to get them to the OR to take care of those injuries or find the appropriate specialist to do so, such as a brain surgeon for a bad head bleed. And that initial workup occurs hand in hand with emergency medicine as well. So they come to the door, say you're injured in a car accident, we'll all be there to take care of you. If you're going to the OR, operating room, that'd be the trauma surgeon that would take it from there. If you get admitted to the hospital, the trauma surgeon will also take care of you while you're in the hospital. So that is the distinction between what a trauma surgeon does. If you talk to many of us, we feel like we are superheroes. Like there is that sort of like we can handle anything. If the stuff is hitting the fan, we are the ones that you want to call to take care of things. And there's certainly a line between self-confidence and bravado and just being completely arrogant. And you just don't want to cross that line. But with that confidence, that comes with training. It comes with being reliant on your team of nurses and students and residents and other doctors. And it comes with knowing that what you are doing is in service to others. It's not in service to yourself, but it's in service to others who are usually strangers who woke up that day and got injured through no expectation of their own. And now they're dependent upon you to ensure that they get back to their normal way of life. But at its core, trauma surgeon is a general surgeon. So my training is in general surgery, gallbladders, appendicitis, colon resections, soft tissue surgeries. So that is the foundation of what we do. And then we specialize in trauma surgery and critical care, which I'll talk about in more detail as you move forward. But just remember, if you want to go become a trauma surgeon after you finish medical school, you need to go to do a general surgery residency. Treat the traumatic injuries. Sometimes you need an operation, sometimes you don't. We talk about penetrating injuries, gunshots and stabbings, and blunt injuries, as we mentioned, the car accidents and the falls. And the other part that separates trauma surgeons from everyone else is critical care. That is the intensive care unit. People that are on life support. You hear about people being on breathing machines and life support. Trauma surgeons are trained to take care of those patients as well. So that's what attracted it to me when I was a medical student was not only did I have the fast pace of the emergency department, not only could I also go to the OR and do operations, but I also got to work in the intensive care unit dealing with this cutting edge technology with patients that are the sickest in the hospital and helping bring them back to their pre-injury condition so they can go home to their families. So how much time will this take? Okay. Mine was 13 years. 4 years of medical school. General surgery residency is 5 years. I did 2 more years because I did some research during that time. That is not required, but I did that. My residency did require it, but it's not required everywhere. A fellowship of another 1 to 2 years. The 1 year that really matters is the critical care fellowship. So when you're done, you will get 2 board certifications. 1 board certification in general surgery, a 2nd board certification in critical care. I did 2 years, which is a year of critical care and another year of just straight up trauma surgery, just nonstop at a very busy trauma center, Grady Hospital in Atlanta, Georgia. I saw a few folks from Atlanta out there, so you may know about that place. So I did a year of trauma surgery just to kind of get myself, it's like getting ready for game time. I wanted to train at a place that was iconic, well known for trauma internationally, and also had some of the greatest teachers in the world for trauma. So I learned from the masters, and I felt fortunate to do that.
Hey,
Brian, when that's all done.
Brian, what was your research project about during your research period?
So for my residency, my research was in hemorrhagic shock. So hemorrhagic shock is basically when hemorrhaging is bleeding to death, and shock is the body's response to that large loss of blood. And specifically, my research was actually an immunology project. So I looked at how the immune system in the body was activated due to hemorrhagic shock. So if you think of your body's immune system, normally it's supposed to protect you from infections such as COVID-19, the common cold. But in hemorrhagic shock, you lose a lot of blood quickly. That system is activated and it actually becomes injurious. And when it's activated, people die from that. So my research was to look at how we can actually slow that system down so that people that lose a lot of blood from trauma don't die from the actual activation from the immune system. So basically, I was looking at molecules.
Was that actually a wet lab, Brian, or did you, what
Yeah,
was your?
we used an animal model. We're using mice and rats. And some of my partners were using larger animals. And side note, because of my experience doing that, I became vegan after that. I couldn't handle doing animal research. And after that, I stopped eating no animal products, got rid of all my leather, set me down a different path for about 10 years for that experience. So I learned something about hemorrhagic shock, but also learned a lot about animal factory farming. That's another presentation, Dr. Fowler, another presentation altogether. But I'm sure there's some vegetarians and vegans out there that can appreciate that.
Brian, sweet potatoes have a mother and a father also. Please go ahead.
So when you're done with all that, medical school, 4 years, at least 5 years of residency, so you're at 9 years there, and at least 1 year of a fellowship in critical care. That's 10 years of training after you finished your undergrad degree. And like I said, I did another 3 years with my fellowship and my research time. When that's all said and done, you can practice. You have your board certification in general surgery and in critical care, and you can go out and practice. And you can do that in private practice, community hospitals, locums, What I've done is be at academic centers. I wanted to be at safety net hospitals. That was what I wanted to do for my practice, hence Grady Hospital, Parkland Hospital. But there are a lot of options you can do as far as trauma, from being at a busy place where I'm at now, where we're having hundreds of gunshot victims per month, to a place where it's mostly just car accidents and low acuity trauma. So there are a lot of options for what you can do. So talk about the research residency time. I did my residency at Brigham and Women's Hospital up in Boston. We kind of mentioned I took some time off for research, and it's during your 4th year of your residency that you apply for your fellowships. And that's when I applied for trauma, and I matched my 5th year when I was a chief. And then I went on down to Atlanta, Georgia, to Grady Hospital, did 2 years there. 1 year was SCC, that's surgical critical care. And the other year was trauma. And as I mentioned before, the year that matters is the critical care year, because that is the one that requires a board certification. Trauma does not. If you finish general surgery, you can practice trauma in this country. However, you won't get to go to a big place like Parkland Hospital or Grady or Chicago without additional fellowship training in trauma. Some places are just too busy, and the injuries are just too complex to not do additional training to take care of those. Oh, I should say, these are some of my resident friends who are still my friends for life to this day. They're my brothers and sisters. You bond in a way during your residency and internship that will last you for the rest of your career, in your life, actually. And these are my co-fellows at Grady. So we can't talk about trauma surgery without talking about the cool cases we do, right? We always have these great cases we like to do. And here's one of the memorable cases I had from my time in Grady, where this patient came in, and he was stabbed wound to the chest. He walked into the hospital, was awake and talking, and just said, "I got stabbed." Well, it turns out that this 6-inch blade that you see there was stuck in his left ventricle, which is the main chamber of the heart that pumps the blood to the rest of your body. It's the strongest chamber. And he somehow survived an injury. We took him to the OR. I was a fellow. The attending and I did this case, and when we opened up his chest, we found the heart beating with this knife sticking out of it. We actually had to lift the heart up off of the blade before we could get it out, and then did the repair, which you see right there, did the repair. And then you survived, came out the clinic a couple days later, there's his scar. As far as I know, he's out there living and doing just fine. And there are like so many cases like this that we can go through: car accidents, gunshots, stabbings. But what I want you to take it from is not just the technical part of what we do, which is what we get a lot of credit for, but there's this human side to what we're dealing with. Is you touch these patients and their families in a way that is unparalleled, because especially ones that are about to die and they live, there's gratitude that comes from that you would not get from anywhere else. And to know that you made a difference in someone's life and for their families, there is no amount of money that could, I know it's hard to quantify how much that means, to know that you're having that sort of contribution to society. So when you go through medicine and you start going through this training and get deep into it, it's easy to lose sight of the humanity of what you do. And if you're not careful, it will be squeezed out of you through medical school and residency. You have to hold on to that no matter how hard, because that's what separates you from every other profession out there that are out there doing good.
Brian, we've already got a host of questions that these wonderful students, well over 1,000, are listening to you right now. We have some really interesting things. What is a typical workday like for you now up in Chicago?
Well, that's a great question. Because one of the things I like about my job is that I don't have a typical workday. every day is different. Say if I have a clinical duty and I'm on call for trauma, I come in and I get sign out, and then whatever comes to the door that day is what I deal with. So you just never know. There may be some scheduled cases like a take back for a patient with an open abdomen. You may have an appendicitis trickle in there at some point, or a bowel obstruction. But for the most part, I don't come in with like, I'm going to be doing these things today. I just basically show up. This is my shift, and bring it on. And when it's over, the next person will take over. So that's for a clinical day that's on trauma call. Then there's also clinical days where I'm in the intensive care unit. So in those days, I'm up in the ICU for the patients that are on life support. And I work there with the nurses and the residents and students. And we're basically caring for patients that are on breathing machines. They may be on dialysis, but they're basically the sickest patients in the hospital. They're the ones that are sedated, they're not awake. We're just trying to support them through their critical illness until the body can respond, and they can heal, and someone gets back to the floor and maybe go home. So I have my days where I'm in the OR for trauma. I have days where I'm not operating, but I'm just in the intensive care unit, taking care of the critically ill patients. And then there are my admin days, which is just paperwork, writing notes. And my big thing now in Chicago is I'm developing a fellowship to train future trauma surgeons. So I spend a lot of my free time doing that. And then in the midst of all of that, you're always teaching residents and students in the OR, in the ICU, in clinic. Oh, I forgot about clinic day. Yeah, clinic's easy to forget. So I have a couple of days of those per week too when I'm on trauma service. So typical day doesn't exist, but I'd say over a typical month, I will do some trauma call day and nights. I'll do some ICU time. I'll do some admin time, and throughout the entire time, I'm teaching.
Brian, when I was a boy and I started medical school, believe it or not, I know I look like a teenager, about nearly a half century ago. And in 1973, when I started med school, if a 40-year-old guy, which was awfully old in those days, came in the emergency department with an acute anterior wall myocardial infarction, a heart attack, we would give him all the morphine he could use, 100% oxygen. This was pre-aspirin, pre-nitroglycerin. We would put him to bed in our brand new CCUs. We would give him DIG and Lasix if his lungs would fill up with fluid, and we would pray that he would not die. And the mortality rate, Brian, if you can imagine, in those days for STEMI, for heart attack, was about 30%. Today, of course, heart attack is an acute endovascular emergency. We have our medics do 12 lead EKGs in the field. We send those to the cath lab, and we transport quickly. Aspirin nitro in the cath lab is standing by, and the death rate now has been as low as 3 to 4%. An astonishing change in technology, Brian, in nearly a half century. Forgive the long preamble. What has been the biggest technology change in your field in trauma? Is it massive transfusion? What has been the biggest technology change that has benefited your field?
I would say the biggest technology change in trauma has been non-invasive imaging, whether that be CT scans or now ultrasound is becoming very helpful. And that's one of the reasons why I really enjoy medicine, is because we're always making advances, and that changes how you do practice. But for trauma, those advances have made it so we don't have to operate on everybody. Before we had that technology, if we didn't know what was going on inside, say we're in a car accident and something didn't seem right, we weren't sure if you had internal injuries, we had to operate. And if you operated and found nothing, then you had this long hospital stay, you had pain, wound infections, you had lifelong issues with possible bowel obstruction. So there's a lot of things that can happen after the operation, even if we found nothing, which is one of the reasons why I'm always trying to convince myself to operate, because I don't want to hurt someone unnecessarily with an unnecessary operation. But with the CT scans and the ultrasounds, we can now see inside the body without actually doing an operation, which means that we've moved from an era of a lot of operations that were non-therapeutic, which means we didn't actually fix anything, we didn't need to do the operation, to a more non-operative specialty where we avoid doing unnecessary operations because this technology now exists for us to peer inside the body without actually cutting on someone. So I would say that that is probably the single biggest change that has, I think, benefited patients, no doubt. But for surgeons that like to operate, it's cut into our operative cases. But we are here to serve the patients, and so I welcome it.
Brian, when you have a case like that guy stabbed in the heart, will you bring cardiothoracic surgery in with you, or are you completely comfortable with just about anything, if it's an aorta or whatever?
Yeah, so for cardiac injury, stabs to the heart, if they arrive to the hospital alive, then 98% of those injuries can be repaired by a appropriately trained general surgeon. So I've used a couple of catchphrases in there. Is one, you have to be comfortable in your general surgery training, and two, that when they arrive alive, what that means is that they arrive alive, they probably did not lacerate a main vessel, a main coronary vessel. There's probably some injury in some big, thick part of the heart that the surgeon can fix that hole. So I am comfortable repairing those injuries. I don't need cardiac surgery, do not need bypass. I can do the sternotomy myself. Now, if they arrive alive and I do the sternotomy and I open up the heart and I see that the injury is kind of close to a coronary artery, and the repair may compromise that, then at that point I would call cardiac surgery to get their opinion about this repair. And that's only happened to me once in 10 years of doing that. But for the most part, yes, I'm comfortable doing that without cardiac surgery, without having a bypass team, and because, like I said, when they arrive alive, they've not hit a major vessel.
Brian, I've been at Parkland almost 20 years. About 15 years ago, the hemoglobin-based oxygen carrier, HBOC, showed up. And we thought for a while that we had this blessing, that we had this liquid we could give that would take the place of blood. Is there an artificial blood yet?
Not that I'm aware of, but I know there are a lot of work to try to develop something like that, which would certainly be would change the game as far as trauma, but also for our military folks overseas, if we can develop something like that, right? Because we still rely on donations of blood to be available for patients that are lost a lot of blood. But blood transfusion is that whole process, as you know, has evolved over time from giving just products to now we're giving mass transfusion to now we're saying go back to whole blood. So the pendulum is kind of swung back and forth on that. But an artificial substitute, I mean, if we could get that actually works, that would just change the game in trauma surgery.
You may know that there's some of the large EMS systems around the country experimenting with whole blood transfusions in the field, notably San Antonio. They carry OPAs, low titer. And interestingly, Dave Miramontes, who's the EMS medical director down there, has organized a group of volunteers. They call them brothers in arms because actually women can't donate because they have the Rh antigen. And they actually give whole blood in the field for folks with hemorrhagic shock, including postpartum hemorrhage. Very interesting.
Wow.
Do you think being in the military affected your mindset in a good or in a positive way as a trauma surgeon, since you have to take the lead and figure things out and handle it?
Oh, absolutely. I think I tell people all this time. So I went to the Air Force Academy for undergrad, and that's West Point has Army has West Point, Navy has a Naval Academy, Coast Guard Academy. The Air Force Academy is another service academy, 4 years, and when you're done, you serve in the military as a commissioned officer. And I tell people all that time at the academy was a seminal event for me. It just prepared me for so many things in life, personally and professionally. You climb that mountain once, and then future obstacles seem less daunting once you've done that. And the friends that I made back then is still some of my closest friends even to this day. And also the engineering background. I think the way I solve and approach problems helped me in medical school and as a doctor as well. And the militaristic background works out perfectly in surgery and trauma surgery, right? Hierarchical, follow orders, do this. So I think it was definitely helpful. I wouldn't trade it for anything. And if anybody wants to go into the military, we could talk about that as well. I'll have my information at the end of the talk.
Sure. About 20% of the folks who log on to virtual shadowing, Brian, are physician assistant candidates. Do you have PAs with you in the trauma surgery?
Yeah, we have APPs and some APNs as well. They're dedicated, they function autonomously. And it's funny you asked that, because just today I received an email from someone up in Boston who wants to come down here to do her clinical rotation with me. So I'm supportive of that. And there's definitely a role for PAs within trauma, whether either a place like ours, academic center that's busy, or community hospital, private practice, there will always be a need for PAs to augment these services.
So Brian, how do you deal with several days of really hard work, tough cases, blood up to your elbows, tough stuff? I mean, do you find yourself beginning to wear mentally sometimes?
Yeah, so the physician well-being is important no matter what specialty we do. And it is true that in trauma, especially now, we're seeing a lot of tragedy. It is a daily occurrence. And I can't remember the last time I was on call that I didn't tell some mother or father or sibling that they've lost someone they love due to gun violence, which is what I'm dealing with mostly here. So that certainly does, it adds up. It wears on you. And for me, it really forces me to think, okay, well, what more can I do to make the communities safer and healthier? Because it is very easy for me to stay in the hospital as a trauma surgeon and continue to treat injured patients. I think I'm pretty good at that at this point in my career. I can continue to teach the next generation as well, which is also important. But there's another piece of this whole puzzle that occurs outside the hospital, and trying to intervene well upstream before the patients arrive at my door, with preventing gun violence, intimate partner violence, motor vehicle collisions. What can I do outside the hospital to minimize injury and death? So so that's what I ruminate on now. That's what keeps me up at night, is thinking about what more can I do? It's just this feeling that, yes, I've gotten this far and I can do this pretty well, but there's certainly more I can do to make society a better place.
Do you think, this is a very personal question to me, because, COVID has really stood in the way of us sitting at the bedside and doing what I enjoy doing, which is, holding old Aunt Minnie's hand and, being with them and helping them get through their issues. Do you think that being a doctor and being a surgeon has made you closer to humanity, to people, or were you already that way? Has it affected you?
It's definitely made me closer and more appreciative of life, and become very hyper aware of my own mortality. I feel that prior to my becoming a doctor, I was open-minded about our shared humanity. I think that became from my upbringing, from my parents, and being a military kid and moving around the world and seeing diverse cultures and people. So I felt I was always open-minded about that part of it. But being a doctor certainly brought me closer to the human condition. You're holding hands at end of life. You're talking to families about what we can do for goals of care. You're seeing patients in your clinic that thought were going to die, but now they're alive. You get cards from people that are now married that you cared for. So it certainly brought me closer to recognizing our shared humanity. But that also, that really was jump-started after July 7th, 2016, after that shooting. That really just set that up that was a rocket ship that took off. It really, really made me re-examine my role on this planet and what it meant for me to be a doctor as far as how I served humanity.
So how do you cope with losing patients, Brian? Because it happens.
Yeah, during a shift, I still kind of shut that off during that time, because we're going nonstop, and the next patient that we see needs us there for them 100%. And the fact that someone died 5 minutes prior, we cannot allow that to impair the care we provide to someone else that is sitting before us. When I'm away, I do either walking just silently, working out, just kind of unplug, and just kind of let my thoughts just kind of flow. And I really have no end goal to try to solve it or answer why, but more to just be with that feeling. Because I feel that the moment that I don't care anymore, or the moment that it doesn't bother me, then clearly at that time I've lost some part of my humanity and connection with the people I'm trying to help. And at that point, I should probably consider another profession. So I do not want to not feel that grief or pain that comes from my patients dying.
Is there a lot of burnout in surgeons, Brian?
A lot of burnout. I will say anecdotally, I'm talking to a lot of people, and I'm hearing they don't use that term burnout, but they talk about all the other things that would constitute burnout are being discussed. Lack of motivation, interpersonal relationship problems, sleep disturbances, looking for other professions. So I think that there's certainly some burnout within surgeons. I think that is across the board in medicine a lot nowadays, especially in COVID. I hear people talking about how they feel devalued in this profession based on the response nationally to this crisis. What does that mean? Do people leave the profession? I don't know the numbers on that. I've heard a story here or there about someone that said I'm done and left because they were burnt out. But for the most part, I hear people that are seen burnt out, but just keep kind of pushing forward for no other reason because they can't think of what else they would do. Right? They've done all this for training. They have this debt. And what else are they going to do? And I would say, what else can you not do? We are so well trained and have so much experience. There's so much more that we can do, that we should not let ourselves be confined to this narrow definition of what we were meant to do.
Brian, you're a physician, you're a great surgeon, and you're a man of color. Did you face any adversities along the way in your medical journey as a man of color?
Well, short answer, yes. So, systemic racism, it still even exists in medical education. It exists in the outside world, and it's one of the things like when I was going through my training, I just accepted it as that's what it is. But I'm not going to let that define me or hold me back. It was actually a motivation for me to strive for excellence, to show everyone that there was no question that I was qualified and able to do the job. But there's things I have to deal with. I'm walking into a patient's room and they tell me to take out the trash. Like, they don't recognize that I am even though I'm in a white coat. Like, I walk in, they just see this black person come in, I'm there to take out the trash. Or having patients flat out say, "You can't be my doctor. I don't want a black doctor." These things have happened when I was a medical student, resident, a fellow, as an attending. So this happens, and I don't think my story is not unique. And I'm certain that there are many trainees and doctors of color that will have similar stories. For me, I just dealt with it in silence. Never made it an issue because I didn't want to bring any attention to myself. And I always felt that if I did, there'd be some sort of professional or personal backlash by doing that. But I recognize that by being silent, I didn't help myself or future trainees that are coming up behind me who are now 20 years after me telling me the same stories. So for there to be progress, we actually have to share our stories, and through those stories and testimonials, that leads to connection. And it's not about punishment or guilt or shame. It's about just recognition that yes, this exists, and we are all here to serve our patients and to serve humanity. And to do so, we have to recognize that we all have different experiences, and they're not, for some, they're not always pleasant, but they form who we are and how we view the world.
So we were all there several years ago, and something horrible happened in Dallas. Could you tell us a bit about what happened? I think you have some slides on that. Tell us the story of that
Sure.
terrible night.
That was another. So this was so July 7, 2016. This was a seminal night for Dallas, for Parkland Hospital, for Dallas Police Department, for me personally. I think there are a lot of people that were affected by this night. This is the night of the Dallas police shooting, where a black sniper was targeting white police officers downtown, and 5 officers died that night. 3 officers came to Parkland Hospital, where I was on call that night with the team. And if you could take you back to that time, just remember July 6th, there was the shooting of Philando Castile outside of Minneapolis, Minnesota, and his death was broadcast live on Facebook, or Facebook Live. And on July 5th, there was Alton Sterling down in Baton Rouge. So there was 72 hours of just death and toxicity, race and gun violence and policing. And then the event occurred on July 7th, and there were actually protests scheduled all across the country to raise awareness of the prior 2 events. But I think the only protest people may remember is the one that occurred in Dallas, because that is the one that became deadly. That's the one that became breaking news. But for me, it's also at a point in my time in my life where I was starting to really question, like, what more can I do as a doctor? And that night when the police officers came in, and Parkland just changed within seconds. I'm not sure if you were there that night, Dr. Fowler or Dr. Marchetti, but if you were there, you remember, like, the ER just looked like a war zone. There were police officers in body armor wearing or carrying AR-15s. The mayor came by, the chief of police came by, all the nurses and doctors were working on these officers that were coming through. And I remember at one point, we lost 3 of the 7 that came to our hospital died that night. And at one point when I talked to one of the families, we talked about how we have to deliver bad news in this profession. When I left the room, I went down the back hallway and I just started crying. And I'm not a crier. I don't cry. I've not cried in so long. But that night, I was just in the back hallway crying. I really can't explain why. Even to this day, I can speculate, but there was just so much about that event that just really tore at me inside. And it's the worst night of my career. And it's something I still think about. I mean, to this day, it's not a day goes by that I do not think about that night. I wonder, we could have done something different, or why is this happening? And a lot of that happened back then is kind of playing out now, right? When we talk about police brutality and racism and gun violence, it's playing out right now in the summer of 2020. And you add COVID on top of that. But that night, worked that night and then went home the next day, then worked the next few nights. And I was so torn up about this that I shut myself off from the world. I did not watch the news, wasn't reading the paper, nothing, because all you heard about was this shooting. And it was already playing on a constant loop in my mind about what happened in the hospital that night. And then came Monday morning, and they were going to have a press conference to talk about the shooting. And I'm certain most people have seen some press conference after a mass shooting and know how they go. And this is one of the defining mass shootings in history because it involved police officers. It was actually the largest loss of life for law enforcement since 9/11. And when they asked me to come to this conference, I initially said, no, I do not want to go. I feel horrible about this. I feel guilty about these deaths. I cannot do this on TV. And told my wife, and my wife was like, get over yourself. You're going to that conference. She was pretty clear, like, Brian, this is Black Lives Matter and Blue Lives Matter and All Lives Matter, and there's all this toxicity and Black sniper, white police officers. She's like, the world needs to see that there were Black people there trying to save these cops because it's getting really ugly out there. And I understood her point. I still didn't want to go, but I did because I thought all I'd do was just sit there. I didn't have to say anything. I just had to show up and just sit there and be visible, which is a statement about race in this country, right? To just be seen, which to me was just another version of being a token at that point, because my opinion didn't matter, but just my presence did. And for some, I still don't even know, like saying that out loud, just still, I don't know how this sits with me very well because I've been to medical school, I've been attending, but at that day I was kind of reduced to this visual presence. But you can see this picture, like, I don't want to be there. I can't even hide it. I can't even fake it that I did not want to be there. But I went. And I'm hearing the press conference progress, and this is not sitting right with me. And here's the thing about, for all of you that are going into medicine, you will have a somewhat reverential position in society. But even without that, you don't even need that, right? Your opinions matter. Your experiences matter. And if you want to stand up for something that matters, you first have to just show up, right? Just show up and then be willing to speak up. Because you never know the power of this one single event and how that will impact others. And I had no idea until I arrived here. Well, I had some idea, but even 4 years later, I still recognized that this press conference was a big deal because I arrived here and people were like, oh, Dr. Williams, I remember seeing your press conference. And I said, it wasn't my press conference. Like, there were 7 of us there. We all spoke that day. But for whatever reason, what I said at that time was what resonated with people. And that could be every single one of you. Like, every single one of you has the ability to make a difference. Wasn't planning to talk. At some point, I don't remember who, somebody asked me a question or the mic came to me, and I thought for a second. So Brian, if you say something, you're going to get fired. I assumed I was going to get fired. But if you don't say something like this opportunity will be missed. And there's a much bigger issue going on. So what are you going to do? And I want to tell you that, like, I thought about that in my head. It was like a second. I did all the calculations, good and the bad, what could happen. And then I'm just talking.
Try your cursor on your click there, Brian. Perhaps
when I click.
Yeah, perhaps your cursor needs to move to the center, perhaps.
Yeah, I'm right on it.
Well,
hang on. I have a fix for this, maybe. Give me 1 second here.
Take your time. In the meantime, I would like to hand along some quotes. Dr. Williams, you are amazing. This is so inspirational. Some really marvelous comments that people are putting in, of the 1,000 people that are currently on Zoom and the many hundreds that are on YouTube Live. Another thing that came across is they said that we love you and we love your wife. Just some absolutely marvelous things that are coming across, including my friend, man of God. And that it's so nice to hear about this aspect of being a physician, Brian, that you're absolutely incredible.
Is this showing up, Dre?
I don't see it, my friend.
Hang on a second.
It may be that Cheyenne or Reagan can look it up on YouTube real quick, and we might try another source of it. I'd love to see it. I saw it, and another says, "You are the embodiment of be the reason someone believes in good people." It says, "Need to stop sharing. Why don't you unshare for a moment and then reshare the screen?" Give that a try. See if that works, Brian. Go down
I think
to
when
where
I
it's,
think what happened when we sent the to add the special slides, I think that's what happened there.
I bet the video didn't come over.
No, I've got it. Just give me 2 minutes here. I'm about to unshare here.
You're totally fine. In the meantime, if you can think outside the box, there was a good question. If you can think while you're working, how in the world, when you have a patient coming in who's so sick and you have all these techniques and information, how do you keep all the techniques and medications and procedures and facts in your mind to treat any patient of any kind? How do you keep all that in your head? I know what I do. It's the experience of, this is what experience does for you. You learn the information, but then you have to see tens of thousands of patients. And what happens over time is that you begin to be able to hold this information in your head. The patient almost becomes a sort of a video of sorts, and you participate in that. I don't know what you think, but that's kind of what I think.
Yeah, it's an experience, and I tell people, like the trainees, about the traumas that come in. It's about seeing these mechanisms over and over, and you start to anticipate what needs to be done and what will happen. And so it's, I don't know, if you play sports, repetition. If you play music, it's repetition. You start to know. If you're an artist, it's about doing that over and over again. It's all about repetition and practice and commitment to the craft. And that's
I remember when I first started med school that as a young student, I couldn't remember stuff on patients. I could write it, I'd write it down, but I couldn't remember it. And then recently a student gave me a high compliment. He says, "You went in that room and you just knew exactly what to ask. How did you do that?" And I mentioned to him that I'd gone into the chart and familiarized myself with some of the patient's history before I went in there. And so going in to see the patient then, what I was doing was filling in. I had the framework and I was filling in, the rungs on the ladder of the framework. That just comes with time.
By the way, I was going to say, I have the video pulled up on YouTube. If you'd like, I can screen share from my screen.
Yeah, why don't we do that?
That'd be easier.
Sure. I found it on YouTube. So, okay, I will share my screen. Okay, that should work. Do y'all see it?
There it is.
All right, perfect. I will play it out.
I want to say first and foremost, I stand with the Dallas Police Department. I stand with law enforcement all over this country. This experience has been very personal for me and a turning point in my life. There was the added dynamic of officers being shot. We routinely care for multiple gunshot victims, but the preceding days of more Black men dying at the hands of police officers affected me. I think the reasons are obvious. That demographic of individuals, but I abhor what has been done to these officers. and I grieve with their families. I understand the anger and the frustration and distrust of law enforcement, but they are not the problem. The problem is the lack of open discussions about the impact of race relations in this country. And I think about it every day, that I was unable to save those cops when they came here that night. It weighs on my mind constantly. This killing, it has to stop. Black men dying and being forgotten, people retaliating against the people that are sworn to defend us. We have to come together and end all this.
And let's reshare
Thank you for that assist. Appreciate it.
No problem.
And it's back to you, Brian. You want to pull your slides back up? And one of the comments that came over on chat was how very relevant this is to today, Brian. What an amazing talk at an amazing time.
Right.
I think I'm pushing 70 and I've been in medicine almost a half a century. I have never seen our country so partisan, and the same sins seem to continue to happen, Brian. And we have such an opportunity as a culture to breed and share love as a society. And I just want to thank you so much for sharing those amazing comments with us, Brian.
No, it's my pleasure. Standing on the shoulders of giants, clearly. Now it wants to play. Oh my gosh, you got to be kidding me. Anyway, so July 7th was the shooting. July 11th was the press conference. And July 12th, there was the memorial in Dallas. And this was happening at the Winspear Opera House. And you see the Bidens came, Obama's, the Bush family, the mayor. And after this was over, everybody left the Winspear. There was the gathering outside. I went back inside when it was empty and sat down in the front row. And I just looked at the pictures of these officers that died that night. 3 of those 5 I helped care for with our team at Parkland. And I just looking at them, at the time I still had extremely vivid memories of what happened that night. And I just had to think, here's where we come in and how we can make a difference is by recognizing that we all have this shared humanity, no matter where we come from, where we're going. Life is fragile, and the same issues that were polarizing the nation 4 years ago still exist now, and we're in a unique position to change that narrative and become advocates and activists for some sort of type of unity and progress. And that's the challenge I have for all of you is, even if you decide not to go into medicine or whatever you decide to do, is just don't ever underestimate the power of your voice. Do not ever underestimate that somehow you can leave a legacy and not even know it. Just continue to always think about doing what's best for humanity. And if you just try to work towards making this world a little bit better of a place when you leave it than when you came in, we all do that together, then that's how we can make a difference. So just to sum it up, if you want to become a trauma surgeon, it's 10 years minimum after you get your degree in whatever it is you want to get your degree in. These are some of my colleagues here at the University of Chicago. We're up on our helipad. And as you see, we're all in our mask 24/7 nowadays. It's a different era. But even after that tragedy in Dallas, even after all of the tragedies and death I'm dealing with now, I know that I have the best job in the world. I know I'm doing what I was meant to do. I have no regrets about what I'm doing, and I cannot think of doing anything else. So I want to wish you all Godspeed on this journey. If you want to contact me, here's my information. Please feel free to reach out. I will get back to everyone. I feel it is my obligation to reach back and help out the next generation that's entering into medicine. I did not get here by myself, and it's my turn to do for you what was done for me. With that, I wish you all a good night. Thank you very much, Dr. Fowler, for the invitation. Dr. Marchetti, good to see you again. Elena, for all the logistics, I want to give you props as well. And for the entire task force for inviting me, I appreciate it. Thank you all. Stay safe. Stay safe.
Brian, thank you so much. Right now on chat, we have hundreds of thank yous pouring in about how amazing you are. What a wonderful story. I recall talking to you not too long after the shooting, and I remember because you were still in a point of, you know, when very significant events affect our lives, nothing says that we process them all at once. We have to think things through. And I remember you were thinking it through, especially the part where you were taking a mortally wounded officer to the operating room to try to save a life. And I remember how deeply affected you were, and I recall when I've reflected on terribly sick people that I've lost, there has been, and I'll talk about this in the Humanity Talk in about 3 weeks. It was there something else I could have done? And I found myself questioning myself. And the later years, I began to realize that no, I don't have to question myself. I did what I needed to do, and I did everything that I could do. And I also showed humanity for the person involved and their families. How have you processed this over time, this terrible episode, Brian? And where is it sitting in your heart today? I think you said it all on that interview, but now today, a few years later, where there's so many events that are still rocking along so similar, where is your heart on the 2016 events today, Brian?
Yeah, I decided that I had to integrate this tragedy into my life, and then somehow make some good out of it, which is propelled me to do other things that I never intended or planned to do as a doctor. When I was in Dallas, I served on the police review board. I do a lot of speaking now. I write, non-medical writing. So things I never considered before, I'm doing that now, because to just let this be forgotten as another event, I think that'd be a disservice to everyone that died and the families, but also to society, because there are so many other issues that I felt fed into that for me to ignore that would be improper. So, like I said, I still think about it every day, but I'm working to make it a part of my life, to do good going forward, but not to define who I am. So I'm sorry, Elena. I know I missed one of your slides here. I think, oh, there it is.
No, it's all good. So we're telling these pre-med kids and pre-PA kids that it's not a bed of roses, huh? That they're going to be tough situations, and that it's actually normal to have tough situations in your career. Is that true?
Oh, absolutely. And I mean, would we want it any other way to not have these challenges, to not be reminded of our humanity, to not be reminded how precious and important life is? If any profession is that, it would be healthcare, right? It would be easy to forget and lose sight of all the other things that make our lives worthwhile without doing what we do. And being able to connect with strangers, it's a privilege, but the reality is, in ways, I get as much out of that relationship as I hope I'm giving to my patients. And I would take that with me every day, and I try to apply that not just in my professional life, but also in my my personal life. And I'm just trying to get better every day. I'm trying to get better every day. I am far from perfect. This is trying to work towards being a better person every day.
You know, something that moves me as an older man is the patients who are really doing the right thing and trying to hold on to their lives, and they are being challenged by some awful illness, a liver cancer or a lung cancer or something that's just, and they're doing every single thing, but slowly, steadily losing the battle a day at a time. And yet they keep trying. And I find those people wonderfully easy to work with because I just feel a love for them. And at the same time, I do feel the fact I wish I could do more. Do you think trauma surgeons seek emotional counseling sometimes, or have outlets for their stress?
Well, I think nowadays, yeah, for sure. I think there's a generational shift in surgery as well as in medicine. We've gone from this very paternalistic type of profession to a more collaborative profession, and generational trauma surgeons now are much more socially active, socially aware about the intersectionality of a lot of social inequities that contribute to trauma. It is not just about the bullet holes and the stabbings and the motor vehicle collisions. It's about, okay, let's talk about structural violence and structural inequities. How do economics in the community contribute to increased violence? How does education disparities and infrastructure disparities contribute to all that? So we're seeing this larger picture and trying to put together all that awareness as well as community psychological trauma to bring a much more broader perspective on how we can serve the community. But it also requires us to recognize our own psychological needs as well. We can't pretend that we are not affected by this and we have all the answers. We have to tend to ourselves as well. So I think there's less reticence to admit to that and to seek help.
On a specific personal note, how do you handle your personal life, your family life as a surgeon? Is it difficult sometime because of your schedule, or is it more like shift work, or how do you handle that?
Yeah, is my wife feeding you questions, Ray? She wants you to ask these questions. So schedule is definitely a challenge. You know, there's nights away from home, weekends, sometimes challenging to miss important family events. So that definitely is there and probably won't change. What has changed, I think I've gotten better about, is the emotional impact of the work and how that interrelates with my relationship with my family. Where before I try to keep it completely separate, as if they were separate. But the reality is, it's not about work-life balance. It's about work-life integration. So what I do in the hospital, that's part of who I am, and hopefully it's making me a better person. And I can use that to be a better father and husband as well, and vice versa. What I learned from my wife and my daughter, I should be able to apply some of that to what I do in the hospital. So recognizing that, yeah, I behave differently in different situations, but I'm still the same person at my core. At my core, I want to serve humanity. At my core, I want to be professional and treat everybody with respect. At my core, I want to recognize everyone for the differences that they bring and how important that is. And in the end, it's about recognizing all of our shared humanity. And that should be something that should just be what I am all the time. I don't shut it off when I go home and turn it back on at work. So,
do you think you'll ever retire? Are you going to keep doing it until you drop one day?
No, I still love being on call on the weekends at 2:00 in the morning when that gunshot comes in. I know it's kind of hard for some people to understand like why I enjoy that, but it's not just that act, it's being on call with the team, like being there with the nurses and the residents and the students. There's something about that camaraderie that I really enjoy. But I do see that I'll probably transition to something else at some point where I take this experience and expertise and apply it somehow in healthcare. I can't define what that is, but I just feel this pull like, okay, Brian, I've got this part down, and I feel pretty good about it, and I could do it for another 20 years and be just fine. But I really feel like there's something I could do to have some sustainable change that will uplift communities. What that is, I don't know, but I will probably move to something else within some undetermined time. How's that for non-answer, Ray?
No, I think that's a very tough decision. You know, I'm 67.
Right.
I've been practicing 43 years. I've worked very hard to be a doctor, and I study all the time. Brian, candidly, I've been a doctor since, you know, all of my adult life. And I kind of can't imagine not doing it and how I would feel about it. So that's a decision we'll all have to make. Let me ask you a specific question. When you're in the OR, how does everybody know their job? Is it in writing, or is it just experience? Or do you tell them what to do, or do they know what to do? The nurses, the PAs, the techs, and so on.
Yeah, everybody has a specific job in the OR. You have the surgeon, of course, with an assistant, usually another resident at least. There is an anesthesiologist who's taking care of all the drugs to put the patient to sleep and control their pain so they don't remember the surgery. There is a circulating nurse who is not scrubbed in. They're not sterile. They're the ones that will be able to answer the telephone or go get additional supplies if needed. And there's a scrub nurse or scrub tech who's with you. They're the ones that, you know, you see on TV, scalpel, they hand you a scalpel, scissors. So they're the ones that are handling the instruments. So surgeon and assistant, scrub nurse or scrub tech, anesthesiologist, and a circulator at a minimum are in the OR, and they're all trained in their jobs, and they know what to do. And really, for me, I don't have to say a whole lot. I get to focus on the case, teach the resident how to do things. Sometimes I just watch them teach another resident how to do a case, and things function usually pretty smoothly. But in the end, the operating surgeon is the one that makes the final decisions about what needs to be done, how we're going to do it, and you're sort of like the captain of the ship. So you have to make sure the ship's going in the right direction. But when the ship's running smoothly, you have to say very little.
A bunch of students have asked us, what is the craziest thing that's happened to you as a surgeon? If that's something that you have an answer to.
So the craziest thing that happened to me, I'll probably answer that in two questions. Well, really, it's really after that press conference. Just I was unprepared for what was going to happen after that. I had no idea that it was going to reverberate around the world the way it did. So after that, I was really just inundated with a lot of requests for media and speaking, and people would walk up to me and said, "Hey, are you that doctor? Can I take your picture?" I was in the middle of Manhattan, walking down the street, and somebody recognized me. So there was this crazy time where someone like me, who was media avoidant and I'd keep to myself, pretty reserved person, suddenly I was just kind of out there, and people wanted to know more about me. So that was kind of a difficult time to navigate, just because I wasn't used to it and wasn't really prepared for it. You know, I talked to the Surgeon General that week. I talked Congressional Black Caucus, international media. It was that to me is just, I look back on it now, I'm like, this is so absurd that all that happened after that. And, well, what do I make of that going into the future? And for me, it's just, okay, you have to give back to the next generation of healthcare trainees, have to give back to society. I can't go back to the way I was before and just kind of curl up into my shell. My wife calls me a turtle, just like to pull my head back in and be left alone. It's out there now. So there it is. It's completely changed my life.
Yeah, a few years ago, you and I went to a community and consulted about the issue of excited delirium and how
Right.
it was, and how sedating people with excited delirium was affecting that community. And it was a very interesting experience, and it was very eye-opening for me, especially about how very, very important it was to include the community in the planning for EMS related issues and law enforcement issues as well. And I think that community had suffered, and you pointed out that out to me, by not being inclusive of the population, especially that all lives matter in the planning community. And you were very helpful and very eye-opening for me. Two more questions, Brian. You've been so generous. Thank you so much. Two quick questions, and then we'll stop. How has COVID affected your work? We had a bunch of questions about that. Are you taking fewer people to the OR? I'm seeing appendices being treated with antibiotics rather than going to the OR. So
COVID essentially meant that we're dealing with two pandemics at the same time. We had the gun violence epidemic and the COVID pandemic at the same time. And we didn't stop. We did not shut down the trauma center. Gun violence actually increased during COVID. And as I mentioned before, we are all trained in trauma surgery and critical care. So I was spending some time in the COVID ICU as well as doing trauma call. So we were we're doing quite a bit. But the one thing that really sticks out to me as far as how it's changed what we do is the first time I had to go tell a family that their son had died from a gunshot wound, and I had to protect them from me and myself from them. I had to assume that they were COVID positive. So I was in a mask and a shield and head-to-toe PPE. And at a time when I'm usually trying to make that connection to a family, to be human and be close, I actually put up this barrier that was very obvious the moment I walked in, that I looked like a space person walking in. And oh, by the way, I'm here to deliver bad news. So for me, the biggest change has been that lack of human connection, that human touch, as a result of having the universal precautions for COVID.
We're also seeing, Brandon and I are EMS physicians, and we're seeing the odd situation of people being reluctant to call the ambulance and sitting at home instead with their chest pain and their heart attacks and not going to the hospital. So we're seeing an increase of out-of-hospital cardiac arrest. Interestingly, I also was reading a day or two ago that, and there are other issues, people staying at home with their abdominal pain and rupturing their appendices at home because they don't want to go to the hospital. Right. It's an odd time. Brian, you've been so generous. Let me ask you one last quick question. Sure. This is something that's always on my mind of late, especially being in a medical school. How do you think artificial intelligence, or as I like to think about it, assisted intelligence technology will affect your life as a surgeon?
Oh.
Or do you? I mean, you're sort of the blood and guts guy, where I'm running differential diagnoses on headaches. Do you think you see that AI is?
No, I'm giving this some thought, because trauma surgery is very algorithmic, right? As they come in, we do our ATLS, A, B, C, D, E, F, airway, breathing, circulation. That has not changed in decades. How can AI help? I think probably the one area where it could help as far as is in massive resuscitations, and using the appropriate, this is me thinking off the top of my head, combination of blood products that we're doing now with our tags, trying to use balanced resuscitation. Maybe it could help in that regard, but that's interesting. I don't know. I've always been like, if they're bleeding to death, let's go to the OR and open them up and fix them.
Right. Emergency medicine has a lot of internal medicine features about it. And one of the resources that's come out recently is called GrepMed, GREPMED.com. I would encourage all the students still online, there's over 1,000 still online, to take a look at that. So you can put in there hyponatremia, for example, and it gives you a very specific way to be able to go and work that up to determine what's going on with the patient. But it's the way of the future, my friend. Brian Williams, you are one of the finest individuals I've ever known. It was a distinct pleasure to work side by side with you in the hospital. It was always a blessing for me to see your smiling face come through that door, because I knew that everything was going to be all right. I love you and we appreciate you. I want to ask everybody on the chat to please say God bless and thank you real quick. And any parting words to our students? What do you give them a final word about going to medical school and PA school?
Say that it's a long road, it's challenging, but the rewards are unlike anything you will get in any other profession. I wouldn't change anything what I've done so far. And I look forward to possibly working with some of y'all in the future.
Brian Williams, a master of medicine. A master of medicine. God bless you. Thank you for your time. And to all of us out online, this is the conclusion of our 12th session. We'll be here as long as you keep coming back. And with that, all of us from the working group, Dr. Williams, Dr. Morsetti, we wish you a good evening. Good night. And Brian, again, thank you very much.
Thank you.
Dr. Williams.
Thank you.
Thanks.
Thank you. Good
Take
night.
care, everyone. Stay safe.